All right. Good morning, good afternoon, wherever you might be on this planet Earth. Hello and welcome. My name is Nicole Gillen, and I'm the Director of Community Engagement here at Schizophrenia and Psychosis Action Alliance. And my role is to create and help drive sessions like today. So I'm going to go ahead and get us kicked off, and I'll be handling some questions at the very end of the session. But first, a few logistics. So, as many of you know who are on this session already, it is being recorded. So if you miss certain parts, you'll be able to hear it online later after we compile the recording and put it up on our website. You'll notice that the only cameras that are on are for the speakers, and everyone will be muted during the presentation today. But if you do have questions, you can use the chat function and send them directly to me. I will be compiling the questions as they come in. If you send it to one of the other co-hosts, they may get it, but they're not going to be able to respond to you. So please direct them to me. Now, let's go ahead and get into today's session. So this is a three-part webinar series on the innovations in treatment to deal with the main symptoms of schizophrenia and psychosis. So why are we doing this? Well, we want to shed light on the full spectrum of symptoms. There are exciting new treatments that our community should know about. And we want to give voice to the people in the thick of dealing with these symptoms. This session covers what is known as negative symptoms. We know all about them, but how can we think of them a bit differently? And so today's session, in terms of the agenda, we're going to do some grounding on what those symptoms are. We're going to hope to, in terms of what we hope to achieve in this session, is a little bit of the science behind those symptoms and what that means in terms of the impact of the people in the community. So, as I mentioned, today is about negative symptoms. Now, as you can see here in the various colors, our last webinar was on positive symptoms. And then our final webinar in February will be on the cognitive symptoms. Each one of these is targeted at giving you strategies, ideas, and practical actions that you can take with you no matter what your role might be in this community. But first, let me take a small step back and talk about Schizophrenia and Psychosis Action Alliance. Who are we? Well, you know what? We focus on shattering the barriers to treatment, survival, and recovery. We were founded in 2008, and we're the only organization really that just focuses on schizophrenia and psychosis. We advance systemic change and promote recovery through research, education, care, advocacy, and public policy, all with the intent of impacting the lives of those with schizophrenia and psychosis spectrum disorders and their loved ones. And we do this in three key ways. First, we have a deep bench of research projects that we both lead and participate in. We have a broad set of services with our resource line and our support groups, and are building a wide variety of educational opportunities, just like today's webinar series. And it all comes together with the ways that we're trying to change public policy through our advocacy work. Our cornerstone programs bring best practice treatment to the forefront, advocate for equal access to care, empower the community with knowledge, skills, and support, and fight discrimination and stigma. So at this point, what I'd like to do is I'd like to pass the baton off to our Director of Research and Scientific Affairs, Arun Nagendra, who will lead the rest of today's discussion. Arun?
Hi, everyone, and thank you all so much for being here. Can we go to the next? Right, so I'm going to start by just talking about our mission a little bit more. We spoke with our community, people with schizophrenia and their caregivers, and asked them to describe what they consider to be their biggest barriers to recovery. This formed the foundation of our mission. We want to build a roadmap to recovery together by tackling these barriers. First, people told us that the current state of treatments for schizophrenia, even the best ones, have limited effectiveness. we need more scientific innovation to actually create treatments that treat the full range of schizophrenia symptoms and their impacts so that people with this illness can reach their full potential. Second, many people struggle to access any treatment. It's actually estimated that only half of people with schizophrenia receive any treatment at all, and then only about 5% receive the full wraparound care that we know leads to the best outcomes. We want to help dismantle these barriers to access. Third, it's estimated that about half of those with schizophrenia in the community live with caregivers, mostly parents, but also siblings, spouses, grandparents, aunts, uncles, friends. These caregivers often take on a huge scope of responsibilities, ranging from support getting to appointments and helping people accept treatment, managing daily activities like cooking, cleaning, and financial planning, as well as providing emotional support and advocacy, navigating complex healthcare and social systems. Despite their critical role, caregivers receive little to no support from the healthcare system and frequently report experiencing financial strain, social isolation, and even symptoms of post-traumatic stress. We want to create systems of care that provide caregivers with all the support that they need. Fourth, there is a lack of appropriate housing for people with schizophrenia. Many people with schizophrenia would thrive if they had housing with appropriate support and the opportunities to build independent living skills. There are nowhere near enough of these types of residences, which contributes to about why a third of the homeless population in the US is estimated to have schizophrenia or another psychotic condition. We want everyone with schizophrenia to have safe, supportive housing in which they can build the skills they need. Lastly, discrimination and stigma deeply impact people with schizophrenia, who are often seen unfairly as dangerous, untreatable, or incapable of leading productive lives, even by mental health professionals sometimes. Globally, up to 90% of those with schizophrenia report experiencing discrimination in areas like employment, housing, healthcare, and social interactions. Beyond personal biases, systemic barriers in policies and services further marginalize people with schizophrenia, limiting their access to essential resources and opportunities. We want to help create a world in which the strengths and skills of people with schizophrenia are leveraged and celebrated, and in which they can connect with and contribute to their communities in the way that most of them report that they want to. Next slide. So I am delighted now to introduce our guest speakers for today. First, we have Joe, who lives in New Jersey. Joe has been on their mental health journey for 14 years. In their spare time, they enjoy volunteering, reading, and taking care of their pet lizards. Joe is diagnosed with schizoaffective disorder and will represent the diagnosed perspective. Next, we have Randy, who lives in Miami, Florida. His wife has a psychotic disorder. He's a businessman who sees the world in a different way now because of this. We have two clinical experts as well. Dr. Kim Muser lives in Boston, Massachusetts. He's a renowned clinical psychologist and leading researcher in treating schizophrenia. Based at Boston University, he specializes in psychosocial or non-pharmacological treatments for those with the illness. He has also made significant contributions to research and clinical efforts to support the caregivers of those with schizophrenia. Dr. Chad Koyanagi is a distinguished community psychiatrist based in Honolulu, Hawaii. He serves as the medical director of the Crisis Continuum and Medication Services Division in the Hawaii Department of Health Adult Mental Health Division. He is a street psychiatrist who is renowned for his compassionate approach and has been helping severely mentally ill, chronically homeless individuals for 25 years. We are honored to have you all here. Thank you so much. Next slide. So before I start interviewing our panelists, I'm just going to give a quick overview of schizophrenia and its symptoms and briefly orient you to treatments for negative symptoms. So in today's webinar, we're going to be focusing on the negative symptoms of schizophrenia, an essential yet often under-discussed aspect of this complex condition. Next slide. To provide some context, schizophrenia symptoms are typically categorized into three groups. The first are positive symptoms, such as hallucinations, delusions, and disorganized thoughts. These are additions. They're called positive symptoms because they're additions to typical experiences. So, for example, someone might hear voices that aren't there or believe they have special powers. Our previous webinar explored these symptoms, and the recording is available if you would like to revisit it. Next slide. The third group consists of cognitive symptoms, which involve challenges like forgetting appointments, struggling to stay focused, having difficulty making everyday decisions, such as choosing what to eat or how to plan a day. This is going to be the focus of our third webinar. Next slide. Today, however, our focus is on negative symptoms, a set of symptoms that are distinct because they involve a loss or reduction of common human experiences. These symptoms tend to persist over time, emerge early, and they can profoundly impact somebody's ability to live a full and fulfilling life. But as we'll talk about, this is only the case when they're not untreated. There is always hope, and there are new and existing treatments that we are going to dig into. Next, please. Negative symptoms fall into two main categories. The first can be thought of as diminished expression. So, and that which consists of blunted or flat facial affect or reduced amount, content, or expression in speech. So imagine having a conversation with someone who shows little to no facial expressions or gestures, speaks in a flat tone, and seems emotionally disconnected, which is what's referred to as blunted or flat affect. What I think is one of the most important things to understand about schizophrenia is that research shows that just because someone isn't showing expression, it doesn't mean they're not experiencing emotions. So, for example, there have been studies done in which people with schizophrenia and people without schizophrenia look at a standardized collection of images used in psychological research that are known to elicit a range of emotional responses. So, for example, if you look at a picture of a little golden retriever puppy, you're likely to feel happy and show that. If you look at a black and white picture of a baby crying by the side of the road, you're likely to feel a little bit sad. Research shows that individuals with schizophrenia and those at risk for psychosis experience these pleasant stimuli as less positive compared to those without schizophrenia. However, the responses to unpleasant stimuli did not significantly differ from those of people without schizophrenia. Moreover, there are kind of measures of like physical measures of emotion, even if people are not showing facial expressions of emotion. And those indicators are actually more active sometimes than the facial expressions of people with schizophrenia. So this suggests that while there's like a diminished positive emotional response to pleasant stimuli in schizophrenia, the reactivity to negative stimuli remains comparable to that of the general population. Next, please. It is accurate, though, to say that some subset of people with schizophrenia do have a diminished emotional experience. So this can take the form of low motivation and energy, reduced pleasure in activities, and social withdrawal. So think about how you feel when you're excited about a hobby or spending time with loved ones. Now, imagine feeling no spark of interest or joy from those activities. This loss of pleasure and motivation can lead to withdrawing from social interactions or hobbies, leaving people feeling deeply isolated. People with negative symptoms can also struggle with what we call goal-directed behavior. So kind of translating their intention to do something into like actual behavioral steps to achieve a goal. Untreated, negative symptoms can make it harder for people with schizophrenia to fully engage in social relationships, work, or even basic self-care, like showering or preparing meals. For example, someone might sit in their room for hours, unable to muster the energy to get out of bed or join family members for dinner. As we'll hear, often negative symptoms are missed or misunderstood by providers, family members, or even those with schizophrenia. However, the big takeaway is with the right support and treatment, there are steps you can take to improve negative symptoms. And we are hoping you'll walk away today with some suggestions of what you can try. Next slide, please. All right, so now I'm going to briefly cover what we know about treatments, and then we'll dig into conversations with our experts next. All right, let's start with medications. Medications are a necessary staple of treating all symptoms of schizophrenia. They are the foundation to being able to do the rest of the work we need to do to support people. For negative symptoms, we know that atypical or second generation antipsychotics are commonly used and they provide modest improvements for negative symptoms. However, new treatments are being explored that target specific brain pathways involved in motivation and emotion regulation. Some of these new medications activate what are called muscarinic receptors in the brain, which play a role in how we experience rewards and engage with the world. Early studies suggest this approach could lead to meaningful improvements in negative symptoms, helping people feel more motivated and socially connected. While more research is needed, these treatments represent a promising direction for addressing negative symptoms more effectively. Long-acting medications are not a type of medication, but more a medication delivery method. These are delivered as an injection, and they can have effects like you can get an injection that could last for 1 month or 3 months or even 6 months. So you don't have to take a daily pill. They are known to improve medication adherence and prevent relapse in those with schizophrenia. Their direct impact on negative symptoms is less clear. Some studies suggest that long-acting medications may offer modest benefits for negative symptoms, potentially due to consistent medication levels and improved overall treatment adherence. Overall, while long-acting medications play a crucial role in managing schizophrenia, more research is needed to conclusively determine their efficacy in treating negative symptoms. Again, though, medications are considered a necessity. They are the foundation for us to do some of this additional work we're about to talk about. Next, please. Beyond this, the most effective treatments we know of for negative symptoms are non-pharmacological, or what we call psychosocial treatments. Cognitive behavioral therapy for negative symptoms in schizophrenia focuses on helping people address patterns of thinking and behavior that contribute to difficulties like reduced motivation, withdrawal, and emotional flatness. This therapy often involves identifying unhelpful or self-defeating beliefs like, I can't succeed, why try, or nobody's going to like me, and replacing them with more balanced and goal-oriented perspectives. They also include teaching people important skills. For example, as Kim User will discuss, we know that people with schizophrenia sometimes have trouble with what we call anticipatory pleasure, or being excited about an upcoming activity, as well as remembered pleasure, so remembering how much they enjoyed something they did. But when they're actually doing an activity, when they're in the middle of it, they're much more likely to enjoy it than they think. So we'll talk about how to psych people up for these activities and reminisce on how much fun they had. Cognitive behavioral therapy for psychosis may also involve setting small, manageable goals and building on them to increase confidence and encourage activity. While it's typically delivered by trained therapists, and in these contexts have been shown to improve motivation, social functioning, and overall quality of life when used, especially when used with medication and other supports, we're hoping today you will walk away with some suggestions for what you can do in your house today. The second treatment we're going to talk about is social skills training. This is a psychological intervention designed to improve social interaction and interpersonal skills in people with schizophrenia. It typically involves kind of group-based exercises like role-playing, modeling, and feedback to practice skills like how do you start a conversation or how do you manage a conflict. The way it works is you pick situations that matter to the person. You really personalize it. So, for example, if you or your loved one are about to go meet a friend for the first time in a few months, you might role play how to start a conversation and how to catch up. And the person doing the role play can provide feedback on things like how much facial expression someone is showing, or their tone of voice, or how to ask open-ended questions, just practicing social skills. Newer versions of this also integrate social cognitive training, building in some challenges that people with schizophrenia tend to have with things like recognizing the emotions of others or picking up on sarcasm. It is one of the most effective and simple treatments for negative symptoms. And some studies shows that it matches the effectiveness of pharmacological treatments in these areas. Cognitive remediation and exercise, we're not going to talk about quite as much today, but cognitive remediation is a therapy aimed to improve thinking skills like memory, attention, and problem solving, which are often connected to negative symptoms of schizophrenia. It involves structured exercises guided by a trained therapist to strengthen these skills and develop practical strategies for daily life. It's most effective when combined with other psychosocial interventions like social skills training, or things like vocational rehabilitation. Lastly, physical exercise is a promising way to reduce negative symptoms as well. Different types of exercise, including mind body exercise like yoga and Tai Chi, aerobic exercises like walking or cycling, and resistance training with weights have all been shown to help. Research suggests that mind body exercises might be particularly effective, showing slightly greater benefits than aerobic exercise in reducing negative symptoms. This might be because they combine physical activity with relaxation and focus, which might help reduce stress and improve motivation. However, aerobic exercise also offers significant benefit, um, and um, and resistance training does too, kind of in that order: mind, body, aerobic, and resistance training. While it shows promise as a treatment, more high quality studies are needed at this point to better understand how to effectively use it as part of schizophrenia care. Next, please. Now, let's move on to technology based interventions. Virtual reality and mobile apps are emerging as innovative tools to address negative symptoms in schizophrenia. VR interventions use immersive, interactive environments through headsets to help people practice social interactions or daily activities in a safe and controlled setting. So, for example, someone might rehearse in a VR setting how to order coffee at a cafe, engage in small talk, etc., to build confidence and reduce kind of this avoidance that can build up sometimes. Mobile apps do things like they focus on promoting daily activity and goal setting through reminders, structured exercises, and real time feedback. So, a person might use an app to set small goals, like going for a walk or completing a task while receiving encouragement and maybe even rewards for progress. Both approaches aim to address negative symptoms. And while they're promising, these are still in kind of the earlier stages of research. And the big takeaway is that they're used generally to augment or complement these other medical and psychosocial interventions. With that said, let's move on to hearing from our experts. Joe and Randy will first describe their lived experience of negative symptoms, then we'll provide the psychological perspective, and Chad will focus on the psychopharmacology, and we'll have time for additional questions at the end. All right. I know, folks. All right. Hi, guys. All right. So, Joe, let's start with you. Thanks so much for being here. Joe, can you describe what negative symptoms feel like?
Negative symptoms feel very isolating. You feel absolutely alone. I have spent years in bed just absolutely by myself. And there's just this emptiness. It's like I was doing everything that I absolutely could as far as like going to therapy, taking my meds, working on a treatment plan, and I had just accepted it as my new normal. I was diagnosed with bipolar at the time, so they just assumed that it was depression, but this wasn't depression. This was like something totally different. The feeling of emptiness and an inability to motivate myself or think or express myself were very diminished.
And you bring up a really important point here, which is that negative symptoms can often be mistaken for depressive symptoms. From your experience, how do depressive symptoms differ from negative symptoms?
Sure. Depressive symptoms mean that I'm sad about something. I'm very weepy. I will cry all the time and have a feeling of sadness. But with negative symptoms, there's simply like this emptiness and nothingness that's completely different.
Thank you. And what are the hardest negative symptoms for you?
Motivation is a big one. Doing even basic tasks, getting out of bed, showering, eating, like all of those tasks can be, it feels impossible sometimes to do them. It's like moving through quicksand to add anything else to basic survival routine. Um, and the worst is socializing. There's a lot of barriers. First, you have to get out of bed, you have to get a shower, you have to put clothes on, and then you have to show up. And then it's awkward socializing with people at a time when like I can't think or verbalize very well. And it's very awkward, even if I'm with my best of friends and my family. So it kind of negatively reinforces itself and leads to this cycle, like, why do I even try? Like what's wrong with me? And I think that the diagnosis that I got really helped me understand that this was just symptoms and like build a better recovery program for me.
And Joe, when you were talking, you told me that there was quite a delay in you even recognizing or being diagnosed with negative symptoms. So, how and when did you realize you had negative symptoms?
When I was 19 years old, I was actually diagnosed with bipolar disorder. And have been in therapy 3 times a week since I was 19 years old. And throughout all of that time, I wasn't diagnosed with my schizoaffective disorder. So in over a decade throughout all of that treatment, they missed it. Um,
And why do you think people missed it?
I think that there's a lack of training in talking about schizophrenia and schizoaffective, diagnosing and treating it. Um, and I think that practitioners find it more acceptable to have negative symptoms or to pass it off as depression, and think that it's just part of this mental disorder to have negative symptoms.
So, after a decade, how did finally learning about your negative symptoms affect you?
The biggest thing was relief. I started to understand that these were just symptoms and that I was not a lazy person. Sometimes I just like could not do things. I felt a lot less stigma and I felt a lot less alone. Because I had like community of other people who had the same diagnosis. Um, it also helped me modify my treatment, build much better social supports, and manage my symptoms better.
And what has helped you manage your symptoms?
I like to take my medication, go to therapy, and then I have like a special formula that I use. Um, so first I cover the basics, which is like hygiene and food. And then I use exposure therapy for socializing, like very low stakes socializing with people I'm very close to, where I don't have to do too much. I'm just present. And then that bigs up that builds up to bigger activities, including like cleaning around the house or going out or something like that. Um, Also, it's just important to remember that setbacks do happen. Healing isn't linear. So for me, I just do things step by step. And then because I've practiced this for so long, my episodes are shorter and I know how to manage them better. Um, so my step-by-step formula looks like getting some external bribery to get out of the house. For me, simple drive through with Dunkin' Donuts, getting out of the house, not really having to interact with people, like very low stakes. From there, I start doing small socialization with my family and my best friends. And from there, I move on to bigger tasks. Caregiver encouragement has absolutely been key for me. Um, my family has become more involved with my recovery the past couple years. And because of that support and little pushes that they give me, it makes an insane difference in how I'm feeling.
And the term used, external bribery, there's actually, we're going to dig into that a little bit later on. You talk about extrinsic and intrinsic motivation. And so we're going to hear more about that later. But you have mentioned difficulties with motivation as a core part of your negative symptoms. Could you tell us more about how that affects you?
Absolutely. So, with the word motivation, I don't love it. Honestly, I don't like the word. For me, it was important to understand that from the outside perspective, it looks like I'm not motivated, but I really want to do those things. It's not a matter of willpower. It is a symptom. So for me, the smaller external motivation works up, and those small actions that I take when I use my formula build up over time.
Yeah, and when you were speaking earlier, we talked about how you had this idea that, you felt like you were lazy, but that's not, and it's understandable if you don't understand what negative symptoms are and how they work, that you might feel that way. And this is just part of why it's so important to have these conversations. So, what kinds of external and internal motivators work for you?
Externally, small, for me, it's iced coffee. It's pretty simple to get me out of the house. I'm also very motivated because of my family. It's very important for me to be close to them. My intrinsic motivation at the end of the day is that I really want to be in my niece and nephew's lives and be present for them. That means I need to be in a good spot in recovery. So at the end of the day, I fight the hard fight every day just because, like, that's my intrinsic purpose.
I like that. Love is a very beautiful intrinsic motivator. Now, what challenges have you faced in treatment?
Um, One of the biggest challenges that I've faced in treatment while having negative symptoms was, first of all, getting diagnosed and getting on the correct medication. But there have been periods where I was so over medicated that it caused negative symptoms as well. Um, there was a point
Mhm.
where I was on 10 different medications, and this was antipsychotics and also mood stabilizers. So at that point, I was sleeping at least 18 hours a day, and I felt like a zombie all the time.
Um, and um, and there's a term for that called secondary negative symptoms when some of your medications might cause what feel like these kind of intrinsic negative symptoms. Last question, second last question. What are your thoughts on trying new treatments?
I think it's important always to keep an open mind. I'm actually somebody who's on newer medications. Now I have less side effects, and I um I have more effective treatment, like I have less symptoms.
And Joe, is there anything else you'd like to add at this point?
I think it's important for other people who have schizophrenia and schizoaffective disorders to know that they're not alone. Like, this is happening, this webinar, to work on things like stigma, and that you need to have that intrinsic motivation from wherever it comes from, so that at the end of the day, you're really locked into your own recovery.
Thank you. And you just reminded me of a note I meant to make at the beginning of this, which is I'm going to be using the term people with schizophrenia a lot. When I use that term, we're talking about schizophrenia spectrum conditions. We're not trying to exclude those, which would include things like schizoaffective disorder, early psychosis, or psychosis, psychotic conditions in general. Just want to be clear on that for everyone. All right, thank you so much. So we'll loop back around during the audience Q&A.
All right,
All
thank
right,
you.
on to you, Randy. Um, all right, Randy, could you tell us a little bit about your story with your wife?
Hi, this is for me.
Yeah,
Yes, I'm sorry. I had just a bit of trouble hearing you. Thank you for having me
oh,
on. Um, so I'll start with a little bit of a journey. So I think my history with my wife has been over three different chapters, maybe. And I want to start by saying there was a point in time in which my spouse was cheerful, chatty, athletic, a great mom, had a group of friends, and we did school things together, and all of these normal sorts of things. We had built a relatively traditional life. I worked. We had a suburban home. That there was a structure that was a little bit of the American dream that I had worked very hard to try to make happen. And little by little, things just gradually began to shift. Um, Things that always seemed normal, particularly when we were out, but at the same time, everything seemed just a little bit more amplified, more difficult, harder to be happy, especially inside the confines of our house. And my spouse used to always struggle with what she called the right order of things. Things had to be in the right order of things. And I didn't understand that. We didn't understand that. My daughter and I went through many, many challenges trying to figure out how to keep mom calm, how to keep mom happy. But we didn't have any awareness at all that there was anything out of the norm. And I think the second phase, as she went through high school, and every moment in which my daughter hit a life change, getting her driver's license, going away to college, moving from college into her life, things just seemed to crater and change a little bit. And COVID, and the isolation of COVID really changed everything. And it took quite a while for us to really understand that there was a psychosis involved, and then a schizophrenia involved, and really be able to determine this. I remember, I just remember moments where now my daughter and I began to have like an illuminated sense that this was a non-normal situation, right? But she also progressed. I think the COVID period of time and the isolation really was the point in which I noticed that more positive to more negative type of behavior. Does that make sense?
Absolutely. Can you hear me okay now?
I can hear you better now. Thank you.
Wonderful. I can even increase my input volume a little bit more. How's this?
Good. It's great.
And now we're cooking with gas. All right. So we know that negative symptoms are often missed over positive symptoms. Looking back, what were some of the early signs of negative symptoms that you might have missed?
You know, I think a lot about, I saw a poster once that said, I wish I could go back in time to the moment when everything began to go wrong, and what I began to notice was that every time that she just began to withdraw from wanting to socialize with friends, from wanting to socialize with sports and athletics and things that she used to enjoy doing, and little by little began to not want to be around for family holidays, and that withdrawn. And that pattern continued until she just began to speak less and less and less, and want to have a conversation less, and pulled inward a lot. And then I began to really recognize that I would see eye movements and jaw movements, and see her talking to herself, and beginning to continually turn inward. And then I began to see what I now understand to be blunted expressions, right? Like, she used to smile all the time, never smiles. She used to laugh a lot, never laughs. Just the silliness that used to come sometimes, just all those things began to fade away. You mentioned positive, you mentioned negative, and I think of it almost like the ocean. I almost think of those positive symptoms as being like the emotions and the clouds and the birds that you can see above the water, and the negative being the things that are submerged below. And it's very difficult for me to understand what her emotions are anymore, because she doesn't talk, and she doesn't express them, and she doesn't smile or really communicate. So I've tried to learn how to do that in nonverbal ways.
Thank you, Randy. And I think you're speaking a lot of truth to how a lot of people experience positive and negative symptoms. Positive symptoms are so much more active and kind of like in your face, and the negative symptoms are much more passive. And I think that's part of why they often get missed or ignored. Um, your wife hasn't been able to get the treatment she needs,
Yeah.
so the responsibility falls to you. What
Yeah.
do you do to take care of her?
I think I'll also say this. I used to struggle with what I thought was her inability to take accountability for things, or sometimes what I thought would be, situations in which I felt like she was not telling the truth, or she wasn't being truthful. I now understand there was my life changed when I learned a term. Like, my life changed when I began to understand something called anosognosia, right? Which is roughly, loosely, lack of insight. And the fact that there were people who suffered from psychosis who had a lack of insight that there was anything wrong with them, and an unwillingness to even entertain the idea of treatment or support, that was a huge, huge awakening for me. and I've been able to see life, and I've been able to see her through a different lens, right? But without any medication, or without her willingness to seek out medication or help, I am the medication. I have to then and follow, I have to be the one to understand how to create the right environment, and how to read what you can't read, how to try to understand what might be going on below the surface of the water. And in reality, Arun, it's easier for me to think about how to change and moderate my behavior than it is to understand how to adjust hers sometimes. And that notion of two things: one, anosognosia, number one, and number two, that notion that maybe I wasn't just a spouse anymore, I was now a caregiver, really began to help me change in ways that, you know, have not improved things, but have been able to make things more bearable and more manageable.
Thank you. And while we were talking, you shared with me what an isolating experience this is, and you talked a little bit about dynamics with clinicians. You said that clinicians talk a couple levels higher, a little bit more in the clouds than caregivers. Can you just tell us a little bit about what you meant by that for the clinicians on our call, especially?
Um, First of all, it's been great for me to find resources and ways of tapping in, and I've taken a responsibility to learn more. The less willing she is to to undertake any care or any medical treatment, the more I've had to be the one to anticipate. However, I don't know. I don't know what I don't know. I am flying a plane without any gauges on it to know which directions to go, to know how fast I'm going. I don't know what I don't know, right? So I just I think of caregivers have this responsibility of like almost being in this diagnostic role, but they're not trained. I'm not trained. I don't know the right medical ways of reading her. So I feel like I'm a gatekeeper sometimes between the clinicians and the medical community, who can be very layered and very smart and very think about medications and the right kinds of medications and how to adjust those medications, or the behavioral things to do. And yet I'm they're moving at speeds that they are at the run stage, and I'm at the crawl stage when it comes to understanding. And I feel like I'm the intermediary. And yet again, the role of a caregiver becomes so big, but at the same time, we don't have the answers. We don't have the training.
I remember early in my job here, I spoke with a caregiver and I used the term caregiver stress. And she paused me and she said, Rune, it's not caregiver stress, it's caregiver agony. So, as a caregiver, tell me how all of this has impacted you.
First, this is a big step for me, even being here today, because I feel like I'm integrating halves of myself. So thank you for that. You know, I'm a driven business person. I have work with a positive attitude. I invest a lot of time in building business relationships, and then I've had this other side of my life, right? So this is like the other side of my life. um, I feel like that log that is in the fire that looks like it's a complete log, but it has burnt all the way through on the inside. And if anyone touches it, it just all turns to ash, right? It feels like I have been consumed a little bit, first by the unawareness, not lack of understanding, and just every day to day life was just so difficult. Things would look good. We would look good on the surface, but just getting anything, any measure of happiness and agreement was just so difficult, because if you weren't in the right order of things and all the related psychoses that went along with that, then a rage was going to happen and other things were going to happen, right? Um, it's been helpful to learn how to tap into resources like this, like SPAA and some of the other support. That's been super helpful, but it's taken a huge toll on me. I feel I didn't realize that, right? But it's almost a war of maybe not a war, but it's almost a constant pull between, am I going to get pulled into her psychosis, or am I going to try to pull her into our reality to try to find a way of being in agreement, right? And it's this pendulum back and forth all the time. It's life in a circus mirror, right? Everything looks normal, and yet everything's got that concave circus mirror kind of aspect to it a little. I feel beat up. I feel tired. And I also feel like the one thing, the longer term thing, and I just feel like I can never relax. I can never let down my guard. I can never let down my guard. I travel for business. I used to have this kind of reputation and sort of joke about being like a gadget guy because I had all kinds of technology, and I would. But at the same time, I had to build a spider web of monitoring around my spouse to kind of keep life together. And I can never take my eye off it. Never, ever. I never relax.
I'm really grateful you're here today, Randy. Thank you for taking that step and sharing this with us. I know it's been a journey. Um, what advice would you give to other caregivers?
Um, don't be afraid to find support and help like this. Like the again, learning what I didn't learn, learning communication techniques, learning the fundamentals from people about the right way to try to manage situations. I think that's super important. Second thing I would say is do not be alone. I have lost so much of our life, and I have lost so much of my daughter's time by us being alone, being isolated, trying to, you try to maintain because you just don't know. I mean, things, it's not like a light switch. One day, it's not like one day, I don't know. I don't know how to explain it, but don't lose time. I think to some extent my life's a cautionary tale a little bit about if something doesn't feel right early, try to get validation for it. Try to find out, talk to somebody. Don't wait too long. Um, I don't feel depression, but I learned a term. I have this thing, and I think it's called ruminative brooding, where I don't have to necessarily have depression, but I cannot stop my brain from going backwards over life and going, if I would have known this, if I would have known that, I could have done this, I could have done that. Why was I traveling and giving her allowance over the household budget when she didn't have the right mental capacity to make decisions and do things? Like I do that over and over again. Don't do that, right? Let it go. And then the last thing I think I would say is there are like-minded people out there who speak the same language, who speak the language of psychosis. The more you have of those, the more you don't feel alone, and take advantage of that.
Thank you so much, Randy. We'll again loop back around during the audience Q&A.
Thank you.
Now we will move to Dr. Kim Muser, who is a clinical psychologist. So, Kim, we talked about 4 different interventions that are known to help with negative symptoms. You mentioned that 2 of these are especially helpful: cognitive behavioral therapy and social skills training. Let's start with cognitive behavioral therapy for psychosis. In a couple of minutes, could you tell us how it works?
Sure. Cognitive behavior therapy is based on the principle that how we interpret or think about a situation influences how we feel about that situation. And while many different kind of things can influence our thoughts in particular situations, sometimes those thoughts are more accurate than others. And so, if a person thinks that other people are going to reject them socially, they may be afraid of approaching other people, and yet that might not be accurate. And so, cognitive behavior therapy involves helping people make the connection between what they're feeling at a particular time is related to what they're thinking, and their thinking might not be completely accurate. And so, how to examine what they're thinking and to change it when it's inaccurate.
Thank you, Kim. And how about social skills training? Can you tell us how that works?
Let me say other thing about CBT. I thought you might ask another follow-up, but with negative symptoms, a lot of people who have experienced various types of social defeats or challenges growing up or in young adulthood often have negative thoughts about themselves and how other people are going to react to them. And so CBT can help people examine those thoughts and challenge and change them and give them a better sense of control over their lives, optimism, hope, and the expectation that other people will, in fact, respond positively, that they can achieve their goals. And so CBT can be really helpful in challenging this sense of dejection and demoralization that often happens after somebody develops schizophrenia.
Thank you, Kim. That was a very important piece to add. All right, so social skills training. Can you tell us how that works in a couple of minutes?
Sure. Social skills training, it has a name that seems kind of elementary, and some people might not like it so much, but it really is one of the oldest time and yet one of the most effective approaches for helping people improve their interpersonal skills. When I say their interpersonal skills, I mean things like their expressiveness, how well they can express their feelings, their specificity in terms of asking for things, requesting things, and their ability to get close to people in terms of their interpersonal behaviors. Social skills training actually goes all the way back to the 1960s when they called it assertiveness training, where the idea was teaching people how to stand up for their rights and the like. But social skills training expands it to a much broader range of social situations, including making friends, getting close to people, having intimate relationships, solving problems, and so on and so forth. Social skills training involves a lot of role playing where people practice skills in pretend situations and get lots of positive feedback and suggestions for how to be more effective. And then also lots of encouragement and help to practice those skills outside of in real world kind of situations. And with the encouragement and with the practice, often people find that people respond to them much more positively than they would have thought. And the practice and the role plays helps people improve their skills at relating to and connecting with other people. So skills training is kind of a different side of CBT in that it works a little bit more on the behavior. And that often when you get people to go out and try different kinds of social interactions, they experience positive results, and that then changes their beliefs. So they often work in unison, but taking somewhat different approaches.
Thank you, Kim. And my experience of social skills training is that people generally really enjoy it when they're doing it, but sometimes getting that buy-in can be a little bit hard. We were having conversations about how each of those parts of that terminology, social skills, training, role playing, makes people go, a little bit. And so we were talking about how people can maybe frame it differently or sell it. I know Nicole Gillen, our director of community engagement, suggested the term like social reorientation. And Randy, I know you also had a couple of ideas for how to pitch that to someone you love.
Yeah, I mean, I think of it like engagement, right? Like, how do you engage with the world, right? How do you engage with people around you? I think engagement is reorientation sounds a little tweaky, you know. It's like what can you do to make someone pull in away from their inner thoughts and their inner like there's a set of voices internally that are pulling them and compelling them and more compelling than the world at large is. So how do you get them to re-engage? Like, you know, so I don't know. That's the term I use.
Thank you, Randy. And I bet different language and different framing works for different people. And if folks have any ideas for how to kind of frame this, please feel free to send it to us in a chat. We'd love to kind of collect these this language from everybody. All right.
Let me,
Oh, go
can I
ahead. Yeah,
let me just
absolutely.
expand on that a tiny bit, Arun, which is that the way that we sell it to people isn't by the name of the program. We basically sell it by finding out what people's goals are. And when you
Mhm.
look at the goals that people have, goals of people with schizophrenia and other serious mental illnesses, one of the most common goals is to improve the quality of their relationships. Many people want more people in their lives, they want more friends. Many people also want to have a closer, sometimes a more intimate a person in their lives. And in fact, we know that loneliness is one of the biggest challenges that people with serious mental illness face, much greater than in the general population. And they say there's an epidemic even in the general population. So what we do is we connect with people around their goals of improving relationships, getting more people into their lives, having closer and more rewarding relationships. And then once we figure out what that is with the person, we present social skills training as an approach to helping people do that. And we explain how it works. We talk about role playing. And I think, as you pointed out, Arun, skills training groups can and should be fun with a lot of positive focus on helping people improve. So I think if you start off with people's goals, the name of the program doesn't really matter as much because people are really interested in trying things to help them get closer to people.
That's such a helpful framing. Thank you so much, Kim. All right. Now, we know that many of these treatments are nowhere near as widely available as delivered by clinicians as we'd like them to be. So, what can caregivers and individuals with schizophrenia do to incorporate elements of CBT or social skills training into their daily lives now?
Great question, Arun. There are a lot of things that caregivers can do. And I think being able to do some of these things can help with some of the emotional turmoil and burden or challenges caregivers often experience in having a close person with a schizophrenia. One thing is to include the person in everyday activities. In particular, everyday activities that may require relatively little of the person, but enable the person to accompany other family members, even in doing a task such as shopping, going out to pay bills, making a visit, or something like that. Just including people in these kind of activities helps get them out, provide stimulation, opportunities for talking and meeting other people. And the low expectation aspect of it can make it easier for people, even with more severe negative symptoms, to participate and feel like they are members of the family and even of the broader community. Another thing that caregivers can do is work on scheduling activities, leisure or kind of meaningful activities together with a loved one who has schizophrenia, and doing this on a regular basis. And if you schedule these kind of activities on a regular basis, then what family members can begin to do is to work with their relative in terms of anticipating a particular thing that they're going to be doing the following week, like let's say going out to dinner, and they can anticipate it, begin planning it together. And then after they turn this into a regular habit, they can also look back on it a few days after the event and talk about what that was like. And so when it comes to the experience of pleasure, remember that one of the negative symptoms of schizophrenia is anhedonia, a reduced experience of pleasure. Well, it turns out that pleasure really involves three things: anticipating something enjoyable, savoring it or enjoying the moment of it, and reminiscing and looking back on it. And we actually know that people with schizophrenia have the same experience in terms of the moment itself, the savoring. They have a little bit more difficulty anticipating, and they have a little bit more difficulty reminiscing. So if family members set up regular recreational activities, leisure activities to do together, that then sets the stage for beginning to help their relative anticipate it in the planning process and reminisce about it, look back on it. And so this anhedonia becomes something that can be overcome by the skill of learning how to enjoy activities together. And family members can play a vital role in making that happen.
Thank you, Kim. Um, as we've talked about, motivation is a common challenge. Can you explain the difference between extrinsic and intrinsic motivation? Why understanding this distinction is important.
Sure. Extrinsic motivation refers to when a person does something in order to achieve some external reward. You might think of money as an external reward, or food, or something like that. And so sometimes people think, oh, we should always be motivated only by internal motivation. And yet, external motivation is one of the reasons many people go to work and do all sorts of things like that. So, external motivation is a part of life. Internal motivation is when a person does a behavior because, in and of itself, it feels good. They're not getting some external reward. It feels good or right, or there's a sense of purpose associated with it. And so a person might be interested in learning and mastering a particular trade. And so they go to school and they learn it and they become good at it. And yes, they're maybe selling it to other people and making an income, but it's internally motivating or intrinsically motivating to the individual. So both types of motivation can be important in terms of negative symptoms, sometimes providing external motivation or reward, sometimes called bribing somebody, can be useful because it can get them out and get them experiencing new things, which sometimes over time become reinforcing or intrinsically rewarding in their own right.
Thank you, Kim. And based on that, how can caregivers use motivation strategies effectively?
Well, one thing is that they can find or they can discuss what might be motivating to a relative. Sometimes, if you simply look what a person spends a lot of their time doing, those kinds of activities can be used as rewards. It can also be helpful to set household rules. This can be done in a kind of a collaborative fashion when one's loved one with schizophrenia is a spouse, but it can also be set in terms of having offspring, where the parents set reasonable rules in terms of living in the house. And that can include things like doing chores and other types of things. As well as expectations that people don't spend all day, for example, in their room or sleeping all day.
Thank you, Kim. And last question. What do you think of these recent innovations in treatments for negative symptoms?
So there are very interesting innovations. For example, there is the development of apps for phones designed to support increased socialization and work towards social goals and things like that. There's also things such as virtual reality, where people can practice interacting with people in a kind of pretend type of situation, where there's a kind of a low cost or low investment required. I think both of these have a great deal of promise. At this point, we don't really have the data showing that they work. I personally think that these kinds of innovations are going to be helpful, but I think that they're even more likely to be helpful in addition to practices that we already have. We've talked a little bit about CBT and skills training, but other things such as enhancing cognitive functioning and exercise. And so I think that the newest advances are going to be more effective, most effective when used in combination with other strategies for reducing negative symptoms and helping people achieve their goals.
Thank you so much, Kim. Um, Hi, Chad. So we are going to now move on to
Arun.
talking with Chad, who is a psychiatrist specializing in treating schizophrenia. So to kick this off, Chad, how do you assess for negative symptoms of schizophrenia? And specifically, given what Joe and Randy both said, how do you distinguish them from depression?
So, of course, meeting with the person with schizophrenia, doing a thorough assessment, hopefully a face-to-face interaction is most ideal. Depending on how early the person is in their illness and how well they're being treated, their perspective of what their negative symptoms are might be spot on or highly accurate, or when people are a little further down their road of schizophrenia, they may have a little bit less ability to capture the symptoms correctly that they're experiencing and conveying that to you. The bigger part is you should always, if possible, involve the family members, especially if they're family members who are living with and caring for the person. I always try to encourage family participation. Family is your best resource in helping the person with schizophrenia, and so getting their perspective on what they're observing and day-to-day observations of the person is really helpful to kind of getting a better comprehensive real-time picture of how that person is being affected by negative symptoms. And the challenge is negative symptoms, positive symptoms, cognitive symptoms. We try to make these arbitrary buckets for them, but they often overlap. And so, it's your question about depressive symptoms and negative symptoms, because some of these are affected by the same neurochemicals and same parts of the brain. Negative symptoms may often look like depressive symptoms, and so by careful history, we try to figure out, and also with what Joe mentioned, sometimes medications can cause symptoms that kind of mimic negative symptoms, and so it's kind of teasing out kind of the nuances of these various symptoms.
Thank you, Chad. One thing we mentioned when we were chatting before is that um, depression feels is more ego dystonic, whereas negative symptoms are maybe sometimes more ego syntonic. Can you explain a little bit about what you mean?
Yeah, so I think Joe also touched upon it too. Um, So in psychiatry, we talk about e ego syntonic means that it's subjectively described by the person as being less painful or less uncomfortable. So tonic would be things like anosognosia or lack of motivation. Ego dystonic would be feelings that are uncomfortable subjectively to the person, and those would be things like feeling depressed, feeling anxious, feeling hopeless, feelings of suicidality. So, although we both types of treatment, both types of symptoms are important to treat. It's just the way we look at these symptoms, because typically the symptoms that are ego syntonic may not be readily reported by the person, and so we have to.
Did we lose Chad? Looked like he was having some trouble with his internet connection. Well, we'll loop back around if he reconnects. Oh, there he is. Let's give him a second.
And while we wait for Chad to get back on, I'm not kidding when I say we have about 60 questions that have come in today. So at any point, we can also jump into those. So I'll leave it back to you guys.
All right, Chad, are you back online?
I'm back. Sorry about that.
No worries. Welcome back.
Back.
I think we caught most of what you were saying. Let's talk about your approach to treating negative symptoms. You talked about the importance of like involving family, but what else is important to kind of consider when people are especially navigating the kind of psychopharmacological or medication aspect of treating negative symptoms?
So, especially in the last few years, we're really learning the importance of long-acting injectable medications. There's a kind of growing, encouraging kind of school of thought and momentum that people who have schizophrenia should a long-acting injectable medication, which are given every month, 2 months, 3 months, 6 months sometimes, should be the standard of care, even for a first break episode. And so by trying our best to get these people on long-acting injectables, which reduce hospitalization, reduce mortality, increase stability, that then we can prevent the clear decrements in functioning that happen between, like, say, a first episode of psychosis and the second. We have all these data with brain imaging that shows between the first and second episode of psychosis, there's a lot of degeneration of brain tissue, and lower baseline is set. And so by doing our best to target those compliance and on the best medications as possible, then we decrease the amount of decline that happens. As a result, you have less prominence of both the positive and negative symptoms of schizophrenia. We also have trouble in the treatment community of looking too much at just the positive symptoms alone, and so we need to focus more on the negative symptoms. Typically, the positive symptoms are the ones that are most distressing to the family because they result in aggression or hallucinations, or the police being called, or the person being arrested. And so by mental health treatment community being more aware of the negative symptoms, and also all the family members are becoming more aware of schizophrenia and all these new treatments, that once we get the person stabilized, and we can have then we can start targeting some of the other negative symptoms to create a comprehensive treatment plan, which includes medications, case management, housing, psychosocial rehabilitation, virtual therapies, CBT.
Thank you, Chad. I'm going to ask you one more question. I know and then we're going to move on to the audience Q&A, because it sounds like they have a lot of questions for you, and I think kind of use our time that way. So what are some of your thoughts on these newer medications and technology for negative symptoms?
So again, just want to emphasize the fact that long-acting injectable medications are becoming a first-line treatment. It's very encouraging that there continues to be a pipeline of research and medication, including ones like Cobenfy, which is targeting a completely different chemical pathway. Probably should be cautiously optimistic about individual medications as they come out, because sometimes they can people can be overly hopeful, and sometimes some medications can have had less had some disappointing results. So um, uh, uh, just looking at the forest, not the individual trees, we should pick medication, and psychiatrists should pick medications for people that kind of address most of the issues, including compliance, positive and negative symptoms, tolerability of the medications. And so just, focusing on treatment of one segment of the illness, like the negative or the positive or the cognitive, without kind of understanding that most medications affect certain better than others, and that in totality, medication uh, that the person does overall comprehensively the best with addressing most of those subgroups of symptoms is probably the best treatment, and then supplementing that with the non-pharmacological treatments.
Great. Thank you so much, Chad. Thank you to all of our speakers for taking the time to be here. I'm going to hand over now to Nicole Gillen to handle the audience Q&A. I know we have a lot of questions.
We have, I think, 70 questions in total, which, and we have not even 10, 15 minutes left to go, and if we want to finish on time. And so if I can ask all of our speakers to put your cameras on, and let's go ahead and unmute, because we're going to do a little round robin here. So, sometimes the question is directed at one of you. Like Joe, I think you had, I'm not kidding when I say 20 questions. Randy, you probably had 20 questions, which I think is really interesting that we had so many more questions for Joe and for Randy than for our clinicians. But regardless, the point is people are inspired by your stories. People want to know so much more. And the number of comments of thanks that I got for you two in particular being here, I can't, I've lost count. So with that as my preamble, I'm scrolling my way back up my list to the very top here. And Joe, I'm going to start with you. And it's such a simple question, but I think it's so powerful. How do I communicate on behalf of my daughter that she is not, quote, lazy?
I think the first piece is education. So for me, learning about the symptoms and like what I am going through, and that it wasn't a personal flaw of mine, instead it was a symptom. And having my caregivers and family understand that reinforced positively that even my smallest actions made a huge difference, and that they continue to accept me even when I couldn't emote or couldn't get out of bed. They always invited me everywhere, things like that.
That's a beautiful answer. And so along the same lines, I now want to flip this over to you, Kim. So the question was, Joe differentiated negative symptoms from depression based on their internal experience. How would a clinician differentiate negative symptoms from depression?
That's a great question. The best way for clinicians to distinguish between the two is to ask the client, to ask the individual about their feelings, their mood. If somebody is depressed, they will indicate that they have feelings of sadness, feelings of loss, and the like. Also, other symptoms of depression may be present as well, such as rumination, thinking about death, thinking about being worthless, and things like that. If the person doesn't have a strong depressive reaction, then it may be negative symptoms. Now, they may not like the negative symptoms, and they may even struggle to cope with them. It's very common that people force themselves to go through stuff, to pursue things, even though they don't have the feeling that they want to do that. But it's still a separate experience from that of depression, the sadness that we know is a common negative emotion.
And so then, Chad, from your lens, when you're now thinking about medications, right? Again, same thread in terms of depression versus negative symptoms. And you made the comment once when we were preparing for today's webinar that you can't just think about negative symptoms. You have to think about the totality of potentially all the symptoms. How do you sort of go through that process in terms of, well, are there positive symptoms involved in this and or negative and or depression? How do you unpack that?
Again, just by careful history from the person and their families, seeing how the course of their lives is going. As we know, people who have, I think people with mostly positive symptoms end up coming to the attention of healthcare and families, and maybe overly look at positive symptoms, whereas people who are just laying in bed may not get the attention that they need. The medications, even the medications that have been around for a few years, do have some effect on negative symptoms, um, measurable effects. And so we need to, again, think about compliance issues and preventing further decrement in care and brain loss by not giving the patients medications which will lead to stability and lead to discontinuation.
Thank you. That was excellent. And I appreciate you guys, all of your perspectives on that. And as I'm sitting here and I'm looking through the questions, I have another one that I kind of want to go through everyone, but we're going to start this time with Randy. Randy, the question is, in my case, my son does not accept the diagnosis and is in denial, so he will not attempt any recovery. Is there any discussion on how these techniques might apply to patients still in denial? And I think that might touch a little bit on your situation. What are your thoughts on that?
Well, the first thing, things got better for me when I realized that her reality is reality to her. And it wasn't a lie, it wasn't a distortion, because I began then to think about it differently. I think the second realization I had was that I was dealing with it totally wrong in the past, and it triggered a lot of anger, it triggered a lot of arguments. So one of the things that I learned was the concept of LEAP, which is a way of communicating, right? So LEAP is an acronym. It stands for listen, empathize, accept, and partner, right? And I started incorporating that, and it doesn't change reality necessarily, but it made communication a little bit more effective, I guess, or maybe non-confrontational is the best way to say it. It's a struggle. I sympathize with you because I have such difficulty in understanding how to get her to see that her view is not maybe correct. So I don't have an answer for you. I wish I did, because I would have solved my own issue.
Yeah, no, I mean, and that's just it, right? And that's why we're here today. Joe, from your lens, I get the feeling from everything and all of our conversations, you've always had an awareness. But was there a moment in time that maybe you didn't and you were like, what are they doing to me? I'm good.
Um, I think for a while I lacked insight um into like some parts of my symptoms. Um, but I was always very accepting of the diagnosis, the first one I received and then the second one I received. Um, and I continued to work on things in therapy. So at like over time it got better.
It's amazing. Like that's honestly. And so Kim, from your perspective then, if you have a patient that is in denial and is not seeking recovery, is not seeking this therapeutic process, what techniques either could a caregiver do or what techniques might you do to help that person out?
I have two thoughts about this. I mean, we know that it is very common for people to have a reduction of insight or awareness into having a schizophrenia and other mental illnesses as well, and sometimes to have a complete denial. So we know it is a common problem. First of all, I think that we could always try to start where the person is at and to figure out what is important to that individual and to ally with them around achieving important things. A colleague of mine actually developed schizophrenia in her 30s. She had a child. She became completely estranged from her family, lost her job, and became homeless. She was eventually brought into treatment successfully by her desire to reconnect with her child. And through outreach, developing a good relationship with her, eventually she was willing to take treatment, to take medication, which had a dramatic effect on her symptoms because she saw this as something that was potentially helpful in connecting with her child. And then she ended up becoming, very, adherent to treatment because of the benefits. So trying to find out what's important to the person, whether it's work, school, relationships, focusing on that. And then there may be opportunities to bring treatment into the discussion, to create some more awareness and the like in the process of working on that goal together. The second thing is that I do think it is reasonable for family members to establish rules or expectations. If you're having a loved one live at home, that might involve things in terms of staying out of the room. It might involve things such as doing things around the house, potentially a school or work, kind of things. Family members can maintain a relationship with a loved one even after they move out. But sometimes these expectations reduce at least some of the most severe kind of negative symptoms that can happen when a loved one lives at home and has no insight into their illness and is extremely withdrawn from all of life.
It's such a complicated disease. All right, Chad, bring us home. Any final comments from your perspective on that?
Uh, so I think just observation of how things are going in the mental health treatment community. I think I'm excited that so many people are at this call today. There's so much more research and treatment available for schizophrenia treatment, and I think it in some ways the families have to do a lot of research and trying to find the best, read about the best treatments, best new treatments, things coming in the pipeline. So I think with the expansion of mental health services in the past 5 or 10 years, that making mental health care accessible to the general masses, including the worried well. I'm worried that people with complex conditions like schizophrenia there are fewer providers who are really knowledgeable about it. So I think if families can read about this stuff and ask questions to the provider, they're one step ahead of the game because I think such a challenging condition to treat with so many new treatments available.
Wonderful. Thank you, Chad. All right, everybody, we are coming down to the wire. And so a couple of things to round out the webinar, and then we are done. The first one is I have a little QR code here. So if you can scan that, that takes you to a survey to give us feedback on how we did today. Give us the good, the bad, and the ugly. We want to make sure we improve. Along those lines, we have one more webinar in February, which will be on cognitive symptoms. If you are not signed up for that, you can go back to our website under our education tab, and there you can see where you can make sure to register for the third webinar. As I said, that one's on cognitive symptoms. I want to thank all of our speakers today, Dr. Muser, Dr. Koinange, Randy, and Joe. You guys all were just phenomenal, and your stories and your insight, I think, is just so helpful to our community. One final note, in terms of takeaways, Arun, do you want to talk through some of the takeaways? Do you want me to do it? What would you rather do?
I would love for you to do it. I also just want to note we will find a way. We know that we got to, I think, a fraction of the audience Q&A. We will find a way to address your questions, and we'll reach back out about that.
Excellent point. Yep. So, okay, in terms of the key takeaways, right? Hopefully, this is what you learned. This is to many people invisible, but it's such an important part of the illness. We are all still learning about it. Chad mentioned it, and it is important to address these negative symptoms to improve social and work outcomes. But there are treatments and steps that you can take. And as we discussed today, there are two types, expressive and experienced. In terms of skills that you can walk away with, medications are an important staple and foundation to treating all symptoms of schizophrenia. Two of the best treatments we have to complement medications right now are social skills training and cognitive behavioral therapy. While they're typically delivered by clinicians, you can use principles at home from them too, including making sure you're including your loved one in everyday activities, doing these regularly scheduled activities together. In that process, building in time to anticipate and remember, and then helping your loved one structure their day by establishing rules or clear expectations for the person to be doing something. And then final point, virtual reality and other technology are being explored, especially as ways to complement but not replace medication or psychosocial treatments. But they are still in early stages and findings are tentative. But there is progress and there is hope. So thank you to everyone for coming today and spending time with us. We hope you all enjoyed it and maybe learned something. And we hope to see you on the next webinar at the end of February. Thank you so much, everyone, and have a wonderful day.